43-year-old female with alcoholic liver cirrhosis. She is child's A, MELD score of 10. She has had 2 variceal bleeds so far. Both were thought to be from esophageal varices and underwent banding. She's now doing fine. Our stomach is clear of any residual blood or anything, as you can see. And she does have a large fundic varix here. So this is the IGV type 1 isolated gastric varix in the fundus area. Let's take a look quickly to see if there are any other varices in the stomach. Ectopic varices, none seen. These are just rugal folds. They do not look like varices. And if we pull back to the GE junction and cardia, I don't really see varices here either. So I don't think she has junctional varices. But she does have esophageal varices that were banded. And we can see some of that here. So there's still grade 1 to 2 esophageal varices that deserve additional treatment. Today we're going to perform EUS-guided coil plus glue of this very large fundic varix. It looks like it's somewhere in the order of 3 to 4 centimeters endoscopically, but we'll see on EUS. This could be a conglomerate of varices. We'll look for the so-called feeder vessel. So the vessel that straddles the wall of the stomach fundus connected with collaterals. Typically for these varices in the fundus, patients have a large gastrorenal shunt. So we're going to look for that as well. And we want to make sure that we plug up the fundic varices well with a couple coils before the glue to ideally prevent embolization of the glue after injection. I'm inserting the curved linear array echo endoscope now, sliding by the cardia into the stomach. We'll just do a quick survey of her hepatobiliary anatomy. Here's the portal. Let's go to EUS, please. I'm in the bulb. Just very quickly take a look from the bulb, and you can see we have really nice flow of the portal vein, the confluence here, superior mesenteric vein, superior mesenteric artery here. Pancreatic head looks normal. We can also see above that the bile duct, the cystic duct joining the bile duct right there and going towards the ampulla, going upstream here. And here's her liver, a little echogenic. Kidney.
This is our biggest one.
Okay, good. All right, that's the IVC. So again, the bile duct, cystic duct converging. PD is now below. This is right at 6 o'clock, the ampulla. All right, so we'll pull back now. So that looks all just fine. And now this is the left lobe of the liver. You can see the outline. It has a sort of a granular, irregular surface, lobulated, consistent with cirrhosis. It looks like the liver is also contracted, smaller. So now we're going to just quickly look to see if there's any ascites present. I don't really see any. This is the spleen, which looks a bit enlarged, but no ascites that I can see. Now we're starting to see all these collaterals here. So let's just get a sense as to, here's the confluence again, as we saw from the head, or I should say from the duodenum, and portal vein going down this way, superior mesenteric artery, we see that. So here's the splenic vein following that below the pancreatic body, towards the tail. There's the kidney now, so we know we're over the tail. Kidney is at 6 o'clock. And now we'll just pull up towards the fundus, and I'm going to turn the scope in towards the fundus, and we will now start to give some water into the lumen. So can I have some water, please, to fill the fundus? And this will help define the fundic varices a little bit better. And we want to start with low mag to see if we can visualize gastrorenal shunt. These patients nearly always have large gastrorenal shunts. You can see some of the blood flow in the, yes please, in these large fundic varices. And you can see it's not just, one, it's perhaps one large varix, but it's all coiled up. Now what we're looking for is to see where the feeder vessel is. So this is outside the wall, right? We're looking outside the wall. You see the MP above. And we're going to look and see where does it appear to go inside the wall. So just looking for that transition. And we would ideally like to do a transesophageal access. So this is the Crus muscle here. That's the angle of His. And below the Crus muscle there is a collateral outside the Crus muscle. So we're, of course, not going to go here. I'm just going to pull it back into the esophagus. You can see some collaterals around the esophagus. We know she has esophageal varices as well. So these esophageal varices are usually drained to the azygos vein. The fundic varices drain to the IVC through the gastrorenal shunts. And just now I'm using the distal esophagus as a window to look at the fundal varices. So you see the fundus below, right? And there's that big varix coiled up, sandwiched in between. So I'm in the distal esophagus. So I'll just point that out so you can see it well. Let's put the Doppler on, in fact. So you can see here, these are the fundic varices. And the fundus is down here. It was filled with water. There's the water. You see it in the fundus, right? So we're going distal esophagus, transesophageal now from the back into this large fundic varix. Right, there it is. So this is actually a beautiful access to this, and this will also avoid any bleeding since we're coming from the back and not through the very thinned out mucosa. All right, so I think we're ready now. We can measure the diameter of this big varix here, and it's 2.8. Our largest coil is 2, but we're going to put 2 of them in. They're also, 15 centimeters long? So 15? 14, yeah. So it's going to make a number of coils. I can't remember exactly how many. I think it's like 4 loops, I should say. 4 loops. And we'll take the Doppler off. So now it's a question of bringing my scope into a position that is a little bit more assistant friendly. And so I'm going to slowly rotate like this. Interesting that here on the liver, you can see this echogenic nodule there in the left lobe at the tip, which we'll just make note of in our report. Of course, these patients are at increased risk of HCC, but that's probably just an area of fat accumulation. All right, so I'm rotating like this to see if I can bring this into a position that's a little bit more assistant friendly, and here it is. So I'm going to bring everything over this way so that I can stand across from the screen and that the assistant has access to the working channel. So we're going to swivel this screen all the way around so that it's across from me. And then I'm going to have an assistant hold the scope. So here, once again, we see very nicely, this is the varix. And we could, but we don't need to put more water into the fundus. But you see here the fundus, right? And so here's the varix. Good, so this is a good position, and we want the camera to show what the assistant's doing mostly, and maybe my hand. And let's now puncture. So we'll go ahead and take the cap off and insert the 19 gauge needle sheath. Just a standard FNA needle, and this has been primed with water, so you can see that there is a syringe here. It's saline. We're using saline because we're using Dermabond, which is octyl-2 cyanoacrylate. It polymerizes more slowly, which is, I think, advantageous. To actually speed that up a little bit, we're using saline, whereas with HistoCo you would use distilled water. Now, this is not what we were going to target. This is a collateral outside. This is the cruce muscle here. I'm going to torque a little bit, and then I'm going to have the assistant hold the position for a moment. So here's the big fundal varix. There it is. So we want to come in the backside. There's the fundus with the water in the fundus. So hold this, please. That's good. Now I'm going to zoom in a little bit. So the first step is going to be to just advance this forward. And it's actually always wisest to advance the sheath first. If you do advance the needle, just make sure you're never pushing against resistance. So there you can see the sheath moving. You see it. I'm going to pull it back a little bit. We're definitely outside of the elevator. So there's our varix, very nicely seen. It's actually a beautiful position right here. I think we're ready to puncture this. Okay, and we've got very nice Doppler flow there, as you can see. So we're ready to puncture. Let's rotate this just a little bit. So you can see it's one varix, but it's all coiled up. So we're going to see if we can get that coil to really go in and fill that entire. I'm going to thrust this in there, because I don't want any tissue to get caught on the needle. So I'm going to thrust this in, and you can just measure this out just to be sure that you're not going through the varix on the stomach end. So this is 2.8. So I've dialed in about that same amount. So let's now go ahead and thrust in. There it is. Okay, good. I'm inside. We're going to aspirate first. We're waiting for blood flow. The assistant's holding the scope in position, looking at the screen to make sure things don't change. Did you get blood return?
Yes, I did.
Good. Now we're going to, good. We're going to inject a little saline just to see the bubbles. There it is. Very good. Now you see it flows immediately into the collateral areas, right? You see that. This is why we're going to putting these coils in there to catch that glue when we inject the glue. We don't want that glue embolizing. Go ahead, please. Yeah, continue. And I'm going to pull back just a little bit because I want to keep this nice freely inside of the lumen of this big fundic varix. And often you'll get a little bit of bleeding into the varix too, so it starts to look a little bit more cloudy. Go ahead, please. Yes, please. We definitely have to put 2 coils, and maybe even a third one. So we'll see, though. We'll see.
220.
Okay. So we're putting in our largest coils here. So you'll see it come out in just a moment. It's very echogenic. And what's important is this, I don't get pushed out. So the assistant's holding the scope nice and steady. You see it coiling very nicely inside the varix. Very good. Continue pushing out. Continue pushing out, and pushes out very smoothly. This goes very easily until it all goes out. And now we're going to remove the stylet, which we use as a pusher to push the coil out. And now it comes our second coil.
We're going to aspirate first to make sure
That's fine,
okay.
Yeah. So it's always good to just confirm you haven't slipped out. Got blood return there. One more time, a little bit of flush just to make sure the lumen, see it's still easily going into the neighboring collaterals. That's no doubt part of the renal shunt there, what you're seeing to the left side. So just, these are spontaneous shunts that the body very intelligently actually creates to decrease the portal hypertension. So these are spontaneous shunts, and you don't want to occlude those shunts. It's actually counterproductive to what the body is trying to do. All right, so we should have our next coil coming in just a moment. Just adjusting, keep going, yes. Should be pushing out, there it comes. Keep pushing in. Very good, very good, very good.
You want a third coil or is that enough?
Okay. If you have one more coil, let's put one more coil. Any coil. Any coil. Let's put one more. These are so big that I really want to pack these up. You can see a little higher up, I'm going to get a coil coming. Please go ahead, yes. This is a case where you really want to pack them in. Okay, good. And the other thing to remember is there's very rapid blood flow in these varices. So what the coil is doing is it's slowing down the blood flow a little. So that also helps prevent embolization. There's just more time for the glue to seat itself inside the varix. Whereas when you have rapid blood flow, it'll very quickly flush out. So as we deploy this next one, I'm going to pull back my needle a little bit just so that I could get that coil to hopefully. Now, sometimes what I'll even do is have a little bit of that coil come outside the esophagus. But that's really, okay, go ahead, please. Okay, see, I'm pulling back a little bit just so I really get that coil now deployed more approximately and the more towards the esophageal wall.
All in?
That's good. Now I think we're ready to inject the glue.
1 moment.
We have nice artifact from the coils. And when we inject the glue, it's really slow. So we're dripping it down. We got blood return again. The nurse confirmed that. And flushing again. So you see there's much less, look at that, the bubbles are not as vigorously moving.
Do you want both
Okay,
glues in
good.
there?
Yeah, both glues, everything. We're going to pack this with glue now and just let it drip in. It's very slow over some 30
40 seconds.
to 40 seconds and just let it drip in. You can see it's just dripping in, and as it drips in, it's attaching to the coils, the scaffold, to retain the glue. And as the glue drips in there, it's going to make that lumen very echogenic. So the glue is very echogenic. So it's going to plug it up as it just drips in there. Drip, 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 giving it time to attach to the woolly synthetic fibers of the coil. And you'll lose visualization. That's why your assistant has to hold everything very, very carefully and make sure that we don't slip back. Then try to adjust just a little bit here. Just pull just a little bit. Yeah, hold that.
You're
Okay.
in, and I'm
Keep
flushing
going.
now.
Two
Two of them went in.
of them. Okay, good. Now as she's flushing, and as she flushes, I'm going to start pulling back slowly. Tell me when it's the dead space is in.
Everything is in.
Good, I'm pulling this out now. And then the first thing I do is I'm going to advance the sheath forward like this into the lumen of the esophagus, and I've pulled back the needle, and it just advanced this forward so that it's away from the tip of the scope, and I'm just going to pull this all the way out. All right, we're going to take a quick look after our injection. Our coil glue treatment. A little accessory spleen there, and there's our spleen, splenic hilum, pull back towards the fundus, and so we know at the fundus when we see the spleen, and we have still some water here in the fundus. So already you see all this artifact shadowing. That's the glue and the coils. And we'll see if there's any blood flow. here. So this is the area. You can see a little bit of flow, but certainly not the way it looked before. And there'll be, of course, some collaterals there with blood flow, but this area here is basically just black. Let's move this over to the middle here. So this right there, you can see it's just black here. And this is what we treated, so now it's completely obliterated. And there's some, small vessels up here, varices, but nothing that warrants treatment. So this is all nicely obliterated. So we'll take the Doppler off again for a moment. So this is the fundus. Now, these are the collaterals outside, and this is the splenic hilum. And of course, here there will be some blood flow. All right, so that's the hilum. We don't want that to be occluded. So we're going to just band a few of the varices in the esophagus. I'm coming back. And here along the esophagus, I'm in the esophagus at 30 centimeters. Look at these huge collaterals. This patient had a second bleed after banding. Done, I guess it was about a year ago or so, and now had another bleed. And one option would be to obliterate the feeder vessels here that connect the collaterals outside with the esophageal varices with glue. That has been done. I've done it, and it's been reported to result in less bleeding, recurrent bleeding. All right, so we're going to pull out and we'll band the esophageal varices. So we're going to band ligate the esophageal varices, but I'll take this opportunity to just take a quick look at the fundus after treatment with coil and glue. You can see the fundal varices now. They always look more prominent after the glue procedure because the glue expands, also creates a very intense exothermic reaction. Some patients actually have fever after the procedure due to that. That's the formaldehyde that's generated from the glue. But it looks really good. You see there's no bleeding. This is just some neighboring mucosa here, but definitely no bleeding from the varices. And we will go back to the esophagus now, and right at the cardia, I don't see any varices. This is the cardia. And I don't see really any, or maybe very subtle, but they're small, not worthy of treatment. And here's where we usually start our banding, but I don't see any varices here that are noteworthy. Here is where I start to see some varices, so I'll start here, and we'll suck this gently up into the cap. All that's important is you tailor to the size of the varices. If they're very big, then you got to suck more aggressively. But if they're small like these are, you don't have to fill the entire cap, because otherwise the patient really gets obstruction and can't swallow for a few days. So again, very carefully, you don't have to be too aggressive here. And maybe we'll put on one more here. Looks like there's a column. Okay. And maybe one final one, we'll see. Looks good. One last one here, I think. Let's see where it should be. Maybe here. They've really flattened out very nicely here, so I'm just going to sort of see where. Try to get also a different columns. Here we go. I think this is better. Good. Let's stop here. Thank you. Well, you can see the glue coil conglomerate extruding from the fundus. Very nice. And you'll note that the glue is attached to the coil here. You can see that here. See, there's the scaffold. And it really is a nice demonstration of how the coil provides a nidus for attachment of the glue so that it doesn't embolize. I think this is just a beautiful testimony to how the coil really, I think, is helpful to minimize the risk of embolization. She has had no further bleeding since her treatment. And you see the varices look obliterated now. All we see now is the coil and glue extruding. All right, so we'll switch to the EUS and we'll take a look and see if any further treatment is needed. All right, so we've switched now to EUS. You can see we've instilled water into the stomach and the fundus area. There's some bubbles here. It's starting to settle down, but we're seeing to the right of the balloon a shadowing. That's the glue and the coil all in this area here. It's extruding, and we're not going to see very well because of the shadowing. We'll throw on the Doppler, and really what we're interested in is just to see if there's any very obvious areas that may need some additional treatment. But we'll just hold very still here. Movement, of course, will create a little bit of Doppler flow. And very slowly pulling back so that as I pull back to look transesophageal, transcrural, hopefully I can see the outline of the stomach. So you can see now the outline of the stomach still. There's the cruce muscle coming and popping just a little bit further back to look trans. So this is outside there, what you're seeing with Doppler. That's all outside. This is also all outside. All of this signal that you see here, these are the gastrorenal shunts, really. So you don't want to inject into this. It'll just flow right away into the circulation. See the outline of the stomach. This is all obliterated. It really looks fantastic. I think we're only seeing the collaterals because all the varices themselves are gone now.